Dr. N.K. Singh is a diabetologist, physician, director, Diabetes and Heart Research Center, Dhanbad. He is the chairman of the RSC at Jharkhand, ex-governing body member of the National API, and he has got over 30 publications. May I request Dr. N.K. Singh to start?
Uh, Good afternoon, Chairperson, sir. And with all thanks to the IDEACON team, let me share my slides. 1 minute. Yeah. So my topic today is very, very relevant as the chairpersons told. Steroid use in COVID-19, who, when and what. As you see here, we have lots of options, but mortality benefit was only seen with the steroids. So this is very important to consider. So before you proceed for anything, first assess it by three great things: by the mild, moderate or severe disease, and devote time to know day one and assess the risk factors. This will give you the impetus what to do next. So what happened? The recovery trial, as you are well aware, everyone is aware that this changed the whole scenario with an impressive 35% mortality reduction among the sickest patients on invasive mechanical ventilation and a 20% reduction of mortality amongst patients on oxygen therapy. So this was the, I think, the game changer, and which they definitely showed the benefit. But very important to understand ki who should get the steroid is this forest plot chart. And this clearly shows you if the patient was not on oxygen, this didn't show any benefit. So it only showed benefit if the patient was hypoxic and it was either on the mechanical ventilation or only on the getting oxygen with hypoxia. So this point is quite clear, and the first part of my talk is clear today, crystal clear by this graph itself. Later on, this WHO REACT working group gave a prospective meta-analysis of 7 RCTs, and this is the best direct evidence supporting corticosteroid therapy in severe COVID-19. But the message is again the same. What was the recovery was showing? Many trials have been done. I will not go in details of those trials. These are all available. But again, this WHO progressive meta-analysis give you a very important message that there is no evidence that response to steroids may vary with age, gender, duration of disease before initiating treatment, the dose and type of steroid. So this would be quite clear. This is the latest things which I am telling you. And as far as the serious side effects are concerned, apart from these are the all 7 trials which I showed you. This is again important. Again, the mortality, duration of the hospital stay and time to virologic cure was not favored if the patient was not hypoxic. So again, this becomes quite clear at all how this steroids molecule works. I will not go in detail, but see here the GRE plus trans-activation and trans-repression are leading to the increased anti-inflammatory mediators and reduced inflammatory mediators. And there are lots of things happening, how this works in the COVID-19. But my second part of my talk, when steroids should be given, and this is very, very important. As you are well aware, there is an early infection phase, stage 1. Then the second phase is important. And it has been divided to 2A and 2B. What is 2A? That develops patient pneumonia but maintains the normal oxygen saturation. And 2B is with hypoxia but requires oxygen support or mechanical ventilation. But remember, even from the 2A, many patients recover very well. And these patients do not require steroids at all. So take home message here is avoid steroids at all cost in the early phase of COVID-19, at least the first 5 days from the symptom onset. But there are situations. Suppose the level is below 94. This indicates you that patient had developed pneumonia and entered to the phase 2. Here there is no problem. But problem is here. Suppose there is a moderate severe pneumonia early in the course of disease, suppose 5 to 10 days, and here suppose the oxygen, this SpO2 level are above 93 or 4. But remember, such patients have been found to deteriorate with time and enters to a stage 3, that is the hyperinflammatory phase. So we have to pick such patients at this point of time, and that is the most crucial decision you have to make. Where there is oxygen normal saturation, do a HRCT at the 6 to 8 days of the symptom onset, assess the CT severity score, and if it is more than 10 on 6, 8 or day 8, should be taken as a warning sign. Such patients are very important. Again, there is a concept that before you are getting a decreasing SpO2, there is something happen known as decreasing the partial pressure of oxygen. And that time, suppose the CRP is more than 5 times, NR ratio is increasing, or D dimer is more than 2 times, it has been found that decreased SpO2 is a very late finding. So here it becomes again very crucial where to which extent you are going to wait. So this is very again important. So this window period, if you pick such patients in time, you save a life. So जब आग लग गई हो उस समय ही बुझाना है, जब पूरा घर जल जाए तो बचा के क्या करेंगे. So that for that we have to monitor, we should aware about the red flag signs, and there are presence of at least 2 clinical symptoms. With all these things, you can pick up such cases. As far as guidelines are concerned, every guideline, NIH, or here you can see NIH, ERS, that is European Society, or even our Government of India guidelines is quite clear today. Steroids have to be given only if the SpO2 is below 92%. So this is quite clear today. So this PPT is very important here. This slide, right time in the right dose and the right duration. So again, from this CME India guidelines, which is very popular, more than 4 lakhs downloads, again say the same thing. It's a very important guideline. From US, again say the same things. But I will see you just in 30 seconds that a post-hoc subgroup analysis within the prospective meta-analysis did not support the hypothesis that only you have to wait like recovery investigators, because this is a post-hoc subgroup analysis, and they say, some panel members say, in practice it is often impossible to a certain symptom onset and that sign of severity that appears late. In that case, it becomes very important what to do. And as far as the what should be done, which molecule should be used, I think lots of discussion now happened here. So dexamethasone, it suppose appears to be a star molecule, long biological half-life, little mineralocorticoid activity, and a cleaner steroids mechanistically. It has superior penetration to the central nervous system but not the lungs, because in the pulmonary part, methylprednisolone penetration has been found much better. This point has been taken, how much is how much. So there are lots of trial now saying that if you use methylprednisolone instead of the dexamethasone, things could be much better, because it has the least mineralocorticoid activity, a quicker onset of action, shorter duration of action compared to dexamethasone, and the risk of long-term side effects like fluid retention, hypokalemia, hypercortisolism, and dysglycemia less likely with the methylprednisolone. So lots of things is here. Even if you compare those studies, everything goes in favor of the methylprednisolone here. So my point lastly is, there is evidence that the mortality benefit of dexamethasone in severe COVID-19 is not a drug-specific thing. It is likely through a general anti-inflammatory effect of steroids. And the higher anti-inflammatory potency of methylprednisolone regime can confer further mortality benefit beyond dexamethasone with these short-term studies only. As far as the inhaled steroids are concerned in the mild cases as recommended by Government of India, this trial, STOIC trial, gave a better result as you see here, but this is a very controversial thing. Later the principal trial came, and later this Covis Pharma group showed no benefit. So it is again crucial. Some studies are again saying the high dose of steroids sometimes in some selected cases can do wonder. So lastly, in pregnancy and also in children it can be given. Lots of things to monitor. I will not go in detail. So lastly, I will say here, as far as the hyperglycemia is concerned, with a short course of steroids in most of the COVID trials, even in the recovery trial, it was found it is less likely that a steroid-induced hyperglycemia or worsening of glycemia control in pre-existing diabetes contributed to any significant way given the fact that the Victory trial. So this should be again clear. And as far as the tapering of the steroid is concerned, for short period of 14 days, less than 14 days, it is not required. It is almost agreed to in the so last slide is what to do. My final point. So who should be given? It is now quite clear that only strongly support all meta-analysis and the systemic analysis and recovery trial that the use of steroids in patients with COVID-19 only require those oxygen support. Steroids should not be given to patients who do not require oxygen supplementation. When the anti-inflammatory steroid should be initiated early in the pulmonary phase to counter the immune dysregulation. Ideal time for steroid initiation is after 8 days of symptoms when virus has very low tendency to replicate and inflammatory response is persistent. And for patients who have significant lung involvement, defined as resting SpO2 less than 94% or a 6-minute walk test is positive, patient may initiate either methylprednisolone or dexamethasone as you like. What? Steroids should be given either IV, orally, or pending clinical severity of the illness as dexamethasone, as methylprednisolone, as a dose equivalent should be 6 milligram of dexamethasone. Last point is, although
Dr.
data
Singh, please
support,
conclude.
yes sir, this is we should prefer for the sensible medicine. Thank you very much. Thank you.
Thank you, Dr. Singh, for your excellent deliberation on when to start steroid and what steroid should be given.